Hi, welcome to today's podcast. My name is Felix Marquez from Orlando Medical Institute, and today's podcast will be on electrolytes. So I'll be discussing the electrolytes as it pertains to the cardiovascular system. So sit back, get your popcorn. I hope you enjoyed this presentation. All right, so today's electrolytes, today what I'm talking about is the electrolytes. So there is a mnemonic known as called SEXPIN to kind of help determine the two major electrolytes, sodium and potassium. So SEXPIN stands for S, the S in sex is sodium, as the EX is for external. So meaning sodium sits externally outside the cell. Everything is going to reference the cell today in this podcast. So outside the cell sits the sodium. And then the P for pin stands for potassium. And then the IN stands for internal, so intracellular, inside the cell. So in a nutshell, sodium sits outside the cell as potassium sits inside the cell, as the two major electrolytes. But we're going to talk about quite a few electrolytes today in this podcast. So let's start with potassium. Potassium is known as K, all right, K positive. So it means it's a positive electrolyte. And potassium, as I mentioned, sits in the cell. The K stands for kalemia, all right? So if I'm a hypokalemia, or hypokalemic, that means I have low potassium. If I'm hyperkalemic, I have high potassium. But all in all, the K represents potassium. So we know it's an intracellular ion, as I just mentioned in the mnemonic we just talked about. So another easy way to remember how I remember that potassium is intracellular, I think about the gas station, Circle K. So the circle is the cell. Inside that cell is the K, which is the potassium. So potassium is intracellular. It's an intracellular ion. It is the major intracellular ion that sits inside the cell. Okay, the extracellular potassium concentration is typically measured in the blood. So now this is very important because I believe this creates a lot of confusion with students. Are we measuring what potassium is inside the cell, or are we measuring what's floating outside the cell when potassium is at its resting potential? So the resting potential, as you probably saw or are going to see in Gary Gratz's podcast, he talks about the action potential and he talks about each one of those. But at the resting potential is when nothing is happening. There's no excitability, nothing is going on. Potassium is inside the cell, sodium is sitting outside the cell. They're where they're supposed to be. So now, when that happens, when we're at resting potential, there is some potassium that sits outside the cell. It's circulating through the blood serum. And that's a typical measurement of that blood, and is measured milliequivalents per deciliter, is anywhere from 3.5 to approximately 5 milliequivalents per liter, I should say. So that's your intracellular ion. So it sits. So we measure. So we do have some potassium that sits outside the cell. So when that number outside the cell increases above 5, now we know our patient's blood serum, as we measure, we draw the blood and we run tests, we see it's above 5. If it's above 5, then we know that this patient has a lot more potassium sitting outside the cell than he should. If it's less than 3.5, now we're talking hypokalemia. That means there's very little potassium sitting outside the cell in the circulatory system. And how we measure that again? Through the blood serum that we draw up when we measure the patient's blood and we run the test to see what their potassium level is. But if we do have anywhere from 3.5 to 5 that sits in the blood serum, then we know we have good concentration of potassium. Everything is normal in the outside as well as the inside. And because we're going to talk about the different diseases that causes those situations. All right, so the potassium level, when it exceeds, as I mentioned, above 5, now we're talking hyperkalemic. When we're talking below 3.5, we're talking hypokalemia. All right, so our normal measurement, and we should know this, is 3.5 to 5. What you're going to find out, and you're going to see through all these electrolytes that I'm talking about in this podcast, it's how Felix remembers a lot of this, is what's the number value that sits outside in the blood serum. So if it's a low number, probably less than, I'm going to say 15, then we know we're talking about an intracellular ion. If that number is great, is high, is way above, like for instance 122, 140, those are high numbers, above 100. So now we're talking extracellular. We're talking about ions that sit outside the cell normally. So that's how I remember. And you're going to see, like potassium as an example, 3.5 to 5. That's a very low number. Because it's a low number, we know it's an intracellular ion. All right? So questions we asked is, so what are the indications for potassium? You know, what happens when we have abnormal potassium? Well, we need to know that elevated potassium can create an electrolyte imbalance. So that hyperkalemia could create that imbalance that we have with these electrolytes. It also could cause cardiac dysrhythmias. So you got to remember that potassium is a repolarizing ion. So it's like the chill ion. He's just real passive. He don't like to really get crazy. He's just smooth and passive. He's nonchalant. He's like somebody from Colorado, you know. You can read between the lines there. So very passive. So he doesn't create excitability like sodium does. All right. So too much of potassium could really chill too much. And what I mean by chill, he's chilling too much, is his potassium level, his heart rate is going to start to slow down. So the higher potassium your body has in the blood serum, the slower your heart rate will become. So I like to give examples. I'm a big advocate or a big person of giving examples of what I like to talk about. So like the lethal injection is potassium chloride. So think about this. If you flood the patient with a significant amount of potassium, then the heart won't beat no more. Because remember, as your potassium levels increases, your heart rate slows down. You give a significant amount of potassium, you're going to cause a cardiac dysrhythmia such as asystole. And that's why potassium chloride is the actual lethal injection. All right? Now, monitoring the patients, we definitely want to monitor these patients. What patient I would really want to focus on in monitoring this patient with potassium issues? And one is somebody who's acidic. Somebody who's metabolically acidic creates a huge problem with potassium, and people don't realize how it's combined, how they associate is what I meant to say, or I'm trying to say, is how they associate. So when you have high levels of acid, when you're metabolically acidic, it actually pushes out the potassium outside of the cell. So you have high levels of potassium in your blood serum because it's coming out of the cell. That's what acidosis does. It really pushes that potassium out the cell. So let me give you an example on the significance of that when we refer to the pH scale, right? We know what pH scale stands for, right? Per hydrogen, which is the acid. So every time you shift on the pH scale, 0.1 on the pH scale to the acid side, you're going to increase your potassium blood serum by 0.5. That's significant. So just 0.1 on the shift of a scale is going to shift my potassium. It's going to elevate it 0.5. That is significant. So that's what happens when a patient is acidic. They become hyperkalemic because the acid is pushing out the potassium outside of the cell into the blood serum. And that's when we become hyperkalemic. So that's why we want to monitor patients who are acidic for these potassium issues. Another patient is somebody who's receiving diuretics. We're going to talk about this in a later podcast when we talk about cardiac medication. But we have three different types of diuretics. We have a loop diuretic, we have a thiazide diuretic, and then we have a potassium sparing diuretic. And they all are diuretics, meaning they excrete fluid. They're going to get rid of fluid out of the body via the kidneys. But each one of those work differently. So the one that I want to just talk about right now, and then I'm going to reference the other three when I do the pharmacology podcast, or when you see the pharmacology podcast, is the loop diuretic actually gets rid of everything. Fluid, electrolytes such as potassium, sodium, it's going to just excrete everything. It just opens up the floodgates of the kidneys to just flush everything out. So when I'm trying to flush out somebody's fluid because they're retaining so much water that I want to give them this diuretic, I really got to take into consideration about what is their electrolytes like. So if I have somebody who's really struggling with these potassium situations, I'm really going to be careful with the loop diuretic. I will go with more of a potassium sparing diuretic because it gets rid of everything but keeps the potassium. So, like I said, we're going to talk more detail into that when we get into pharmacology of the cardiovascular system. So, we got to be careful and we got to monitor patients who are on diuretics, very strong diuretics such as loop diuretics, because it can actually make them hypokalemic. It could really drop them. So those are two patients that I would definitely pay attention to if I had that. So what would cause an increase? Probably a question you're thinking about is, man, what would cause an increase of my potassium levels? What would cause my potassium levels to increase? Well, if the patient has renal failure, they have end-stage renal disease or renal insufficiencies, they're not flushing out excessive amount of potassium because the kidneys are sick or they're not functional at all, then your body's struggling to balance potassium. He cannot get rid of excessive potassium. So what happens to your potassium levels? They elevate. Once again, if they elevate, what's going to happen to your heart rate? It's going to slow down. So it becomes this domino effect when you have a high level of potassium. So renal failure would actually increase and make you hyperkalemic. Another thing is Addison's disease. Addison's disease, we'll talk about that when we get into endocrinology, but it deals with cortisol. And it creates that imbalance. Once again, the endocrine system, we're talking about the functionality of the kidneys. Kidneys are responsible for regulation of potassium as well. Some injured tissue. When your tissue is injured, any tissue of the body becomes injured. It could spike your potassium levels. So you can have an increase of potassium in your body. Diabetes, huge. Diabetes, we're going to talk about that too in the endocrine podcast. I can't wait to talk about that one. We'll probably tag team that with Gary. A phenomenal presentation. You guys will really enjoy it. But diabetes is a huge disease that can alter your potassium and actually increase it. Diabetic ketoacidosis, that falls under diabetes. Hyperventilating. If you hyperventilate, you blow off acid. That could become of an issue. Severely acidic. We just talked about that. So my body's severely acidic is going to push out the potassium outside the cell, increasing my potassium blood serum. Infections, dehydration, burns is huge. So those are things that can actually elevate your potassium levels. So the next question is, if we're talking about what can elevate it, well, what can cause a decrease in my levels of potassium? Well, excessive insulin, excuse me, and insulin actually depletes potassium. That's why you'll see patients who have high potassium levels secondary to renal insufficiency, the docs will give insulin because insulin depletes potassium, as well as albuterol. So albuterol nebulizers, that also depletes potassium. So if I had a patient who had was hypokalemic for whatever reason, and he's having an asthma attack, you got to take caution about giving those patients albuterol treatments because it could drop the potassium levels. So nothing I want you to panic about, just something I want you to keep in the back of your mind to say, ooh, this patient might have a potassium issue and albuterol might affect that, or vice versa. If they're high levels, then I'm not worried about albuterol. Actually, there might be a benefit to that. All right, excessive diarrhea or vomiting, that could decrease potassium levels. CS, cystic fibrosis, that could really mess up your potassium levels, decrease them as well. And Cushing's syndrome, we'll talk about that in endocrine as well, but that can also decrease your potassium levels. So those are I wanted to just give you some ideas of things that can cause elevated potassium, which we refer to as hyperkalemia, and then I want to give you some examples of things that can drop your potassium levels, making you hypokalemia. So as we move forward and talk further into potassium, when you do have high levels of potassium, hyperkalemia, we're talking, 5.5 to 6.5, can result in the classic peak T's that we refer to in cardiology. So we know the T wave. If you watched Gary's podcast, he talked about that T wave, what it represents, and it represents repolarization of the cardiovascular system. And as I mentioned earlier in this podcast, I said potassium is predominantly the repolarizing ion. So he's responsible for repolarization, so you get that T wave. And when you see that T wave, we know we're dealing with potassium, all right? But when potassium levels kind of exceed 7 milliequivalents per liter, we're talking a flattened P wave. P waves will start to flatten out. That you might mistake this for a junctional rhythm, or you might say junctional Brady or junctional escape rhythm or accelerated junctional. You can see that could be mistaken for that. All right. If you have low K levels, can result in muscle pain or even cramping. You can start losing your reflexes, which is important that you don't lose those. Nausea or vomiting, and you can start having orthostatic changes. So you can have a different blood pressure laying down versus sitting versus standing, all right? So having too much potassium in your blood serum is dangerous. Potassium affects the way your heart muscle functions, how it works. So the functionality of your heart really depends on potassium levels. All right, when you have too much potassium, your heart may beat irregular. You might develop an irregular heartbeat, which in the worst case can cause a heart attack. So in a nutshell, what I'm trying to get at is maintaining those potassium levels is significant. All right, we got to maintain a balance. So those high levels can cause cardiac abnormalities, as we talked about, and particularly at the AV junction and the intraventricular blocks. So you can start seeing problems with those two areas when we start having high levels of potassium. So sometimes that could be a transient block, where it could be temporary. It could be a block not caused by a heart attack or by failure of the AV node. It could be secondary to the significantly high levels of potassium that's causing these atrioventricular problems or atrioventricular blocks. All right, when you start exceeding 9 milliequivalent per liter, now we're talking about atrial arrest. Now you're talking the atrium's not firing at all. All right, so those are good to know stuff. Is this stuff that we're going to recall all the time when we're out there working on a truck as a paramedic? Probably not. But I mean, it's something to recognize if you think, wow, I think this is a potassium situation. So a scenario I would give you is, I got a patient with end-stage renal disease, missed dialysis, he's bradycardic, T's are somewhat peaked or not 100%, but we see flat T waves or P waves, no P waves whatsoever, rate is slow, and he's showing signs that his presentation is telling me he's probably hyperkalemic, and then I see a junctional-like rhythm, meaning is atrial arrest. I'm gonna think this is really high potassium levels. I know we're looking above 9, which is severely dangerous. So those are things that I like to. This is what I use as a medic out there in the field when I start seeing these things. I put 1 + 1 equals 2, of course, right? So I start putting these things together. That gives me the big puzzle of, wow, this guy is severely hyperkalemic. All right, because unfortunately we don't have the ability to draw blood pre-hospital to see what their potassium levels are. All right, so when you do have high levels of potassium, Insulin could be administered. We don't do that pre-hospital because we don't carry insulin. But you might see this in hospital, so it's not alarming to you when you see a physician or a mid-level provider or a nurse actually give a patient who's hyperkalemic insulin. So at the same token, somebody who's taking insulin who's not hyperkalemic, they could become hypokalemic. So it could cause shifting of potassium from outside the cell back into the cell, decreasing the potassium blood serum. All right. So when this starts to shift, it can actually shift, which can cause an increase in secretion in potassium via the GI system and the renal system, and that could become a major problem. So just keep in mind when insulin starts shifting that potassium into the cell by stimulating activities of the sodium, what it can do is actually promote the entry of sodium into the cell, which could lead to activation now of the sodium, all right, and also the ATP. So now it causes excitability of these cells that we don't want to excite yet, and you can have those abnormal or premature electrical beats. So, and that can cause actual influx of potassium into the cell. All right, so IV insulin leads to the dose-dependent decline in serum potassium levels. So those are the people that we worry about, those who are dose-dependent, of start to having fluctuation of their potassium levels. So shifting potassium or shifting K, as you want to say, from plasma back into the cell. And what it does is intravenous glucose, they'll end up giving that intravenous glucose anywhere from 25-50 grams of dextrose, plus they'll give 5 to 10 units of regular insulin to reduce that potassium level, to decrease it. And that normally happens within 10 to 20 minutes. And the effects, the good thing about this, these effects of giving this insulin can last anywhere from 4 to 6 hours. All right, so, and lack of insulin could cause the breakdown of fatty cells. So we know that, which releases these ketones into the blood system, which turns into acid, which does what to potassium? Makes the body metabolically acidic, that now pushes the potassium out of the cell, causing a huge problem. All right? So let's talk about the flip coin. We just talked about hyperkalemia. Let's talk about hypo. So we're talking serums below 3.5. So when you're below 3.5, we're talking hypokalemia, which can cause any one of these things that you see right here on the big screen TV, which is atrial flutter, could cause heart blocks, as we mentioned earlier, bradycardia, and obviously ATLS and hypokalemia that can lead to actually torsades, right? Which is the polymorphic VTAC. All right. So other manifestations of hypokalemia could include muscle weakness. These patients could complain of muscle weakness. This also can cause rhabdo. So the body could start breaking down muscle tissue, which is horrible. That could really shut down your kidneys and create major problems. It could also increase your ammonia levels. And if there's any toxin that your body any chemical that's severely toxic to the body, it's going to be ammonia. So, and your body could start now producing high levels of ammonia. All right, which increases bicarbonate reabsorption. This can cause that as well when you're hyperkalemic. It can alter your sodium absorption completely, and it really, really affects hypokalemia in your nephrons, which can elevate blood pressure. So it becomes this domino effect is what it really does, is what I'm trying to get at when you're hyperkalemic. So the best thing is to maintain a normal potassium level, but understand as a paramedic that fluctuation of my potassium either way, right? Higher than 5 or really 5.5 or lower than 3.5, we're gonna have some cardiac abnormalities that can actually create other systems to fail. So we got to pay attention to that, all right? As far as the ECG changes, what will we see in our ECG? You're going to have ST segment depression. You can see that. You can have that T wave will start to flatten and join that U wave. The U wave will kind of get a little bit larger than the T wave as potassium levels will start to fall. You can have QT intervals appears to lengthen, so they're going to get a prolonged QT. And then the PR intervals could increase that would actually look like a AV heart block. So that's what that could do. So as we shift on to another another electrolyte, this is called calcium. So calcium is abbreviated Ca with 2 positives, right? And what is this action? It's the abundant mineral in the body. And calcium is super, super important. I like to think of calcium as, you know, the strength, you know, the muscle of the body, because what we're going to learn is calcium helps with contractility, really helps with the force of contractility. So if you have good calcium, it's gonna make that, and it also hardens whatever it bonds to. So the normal range of calcium is 8.5 to 10.2 milligrams per deciliter. So look at that number. That's a low number, right? So you see right here on the board is super low. So 8.5 to 10. So we already know, since it's a low number, calcium is an intracellular ion, all right, directly responsible for contractility of the muscle, heart muscle, the cardiac muscle. So it really plays a role in contractility. But the key thing here with calcium that I want to point out is calcium is responsible for muscle contractility, the strength of contractility. But the muscle got to be able to contract. So if you have a person who's dead, their heart muscle is not functioning. So calcium is not going to make it contract. So calcium is only given to people who are hypocalcemic, who need calcium so we can help with the contractility. So if they're dead, giving calcium is not going to fix the situation unless they are hypocalcemic. Other than that, we want to stay away from giving that calcium. All right, so it helps determine rate, works inversely with magnesium, so it kind of works with mag, but kind of slightly different. I like to say it's the same but different, you know. So hypocalcemia, right, is hypo meaning low, and is defined once again, what is that blood serum? So if that blood serum is below 8.5, now we're talking our calcium levels are too low. We gotta have at least 8.5 to 10.2 is what we're looking for. But you usually don't become symptomatic, and this to me, I think this is a key point, is look how low calcium has to be before you might become symptomatic. So symptoms won't normally start until you drop below 2.5. So you could lose a whole lot of calcium before you realize it's a major problem. So that's why it's important these patients too, who has these issues, to obviously continuously follow up with their physician to evaluate these levels. So a prolonged QT interval can happen. QRS, ST changes that can mimic an MI, and then ventricular arrhythmias can happen. It's very rare, but it could happen. So calcium plays that major role. I can't reiterate the major role it plays with myocardial contractility. Severe extracellular hypocalcemia impairs that contractility of the myocardium. So that could be a major issue, all right? And it's gonna really jack up the heart's ability to contract. The ECG hallmark of hypocalcemia remains a prolongated QT interval. So you're gonna see you have a prolonged QT interval. So I hope my analogy of calcium and magnesium, kind of remember I told you they work inadvertently, right? So I like to think of a club, right? We all like to go to the club, at least when we're young, we all like to go to the bar, the club, and we know a lot of these high-end clubs, you gotta be selected to get in, and you stand outside on the line waiting to get selected. So normally who selects you to go in the club is normally the small, skinny little guy who probably was picked on in high school, and he finally got a cool job to allow people to go in the club, and he could really tell people yes or no, right? So I like to call him, you know, his nickname is Magnesium. So he regulates who could come in and out, right? As calcium, as I mentioned, is the muscle. So that's the bodyguard. That's the guy that sits behind Magnesium, right? That little guy, Magnesium. And he's the enforcer, right? He helps you muscle. So I like to say calcium deals with the muscle. That's the bouncer. So it deals with the muscle, helps the contractility, stronger muscle, right? Pushes those people back, pushes them in when need to be. So where do they sit? Well, they're inside the cell. So really that barrier rope is part of the club. Other side of the rope is outside the club. So you are extracellular as the bouncer, who's calcium, and the little guy who's letting people selecting who gets in is Mr. Magnesium. They inside the club, so they sit inside the cell. So his job is to allow to say, okay, you can come in, you can come out, you can go in. So with that said, in calcium also he helps enforce that. So when I have low levels of calcium, whoa, we don't have too many bouncers or security inside this cell, this club, the club cell, we'll call it, right? So we don't have too many bouncers. So what we got to do, we got to delay the entry of personnel into the cell, club cell, because we don't have the calcium, right? We don't have the bouncers to regulate everybody inside the club. So we have to slow off. So what happens? The Q and the T, right? The quality time inside the club, right? QT, the quality time in the club it's going to prolong. You're like, damn, I'm not going to be able to go into the club now because I got to sit outside because calcium and magnesium, they're not here. They let me in. So what happens? Our QT, right? Quality time in the club is now delayed, right? So knowing that if I don't have a lot of bouncers or a lot of magnesium, then I can't get in the club. That's going to be delayed, right? So that's what I like to say when it comes to that, right? Because now we're going to flip the coin in a minute, okay? So now we have hyperkalemic, right? So what does that mean? Well, man, we got a lot of bouncers. I mean, we probably got more bouncers than we have people in the club, right? Club cell. There's a lot of calcium in there. So hyperkalemia is when we're talking about that calcium concentration is going to be probably between 12 to 15 milligrams per deciliter, right? That high blood serum is elevated. So I have a lot of bouncers. I have a lot of people, a lot of bouncers in the club. That means I can allow a lot of people in. So what's your time at the door? That QT time, that quality time, that thing is shortened, man. We're going to let you in real quick. So what does high levels of calcium do? Man, it shortens your QT intervals. So we know if we don't have a lot of calcium, I'm hypocalcemic, I'm going to have a prolonged QT interval. If I have a shortened QT interval, meaning I'm hypocalcemic, I'm going to have a very shortened QT interval, all right? So what that's going to cause is actually myocardial contractility, and when you start exceeding those levels of 15 milligrams per deciliter, it's going to cause some major problems with the contractility. All right, so that's how I like to refer to as how Felix remembers, you know, who prolongs and who's gonna prolong and who's gonna shorten my QT interval, and that's calcium and magnesium. Why those two? Because those two regulate who comes into club cell. All right. So hypercalcemia, when calcium levels are greater than 15 milligrams per deciliter, we're gonna have myocardial depression. So you have depression of myocardium, is not going to contract the way it should. Automaticity starts to decrease. I mean, everything starts to decrease because your calcium levels are so high. You're going to have a severely shortened of the ventricle asystole, and you could develop arrhythmias, because what can happen is they could start firing on top of each other, causing a lethal cardiac dysrhythmia. All right. So as we talk into magnesium, I kind of segue into this a little bit about magnesium. Is that little guy, right? It is the little guy who lets people in the club, and we know his name is, they call him Magnesium, right? What's his actions? He's necessary to move. He's necessary. He's important for sodium to move into the cell, right? Who's sodium? That's you guys on the outside trying to get into the club. So your sodium sitting on the outside, the border of the cell, like, God, I want to come in, you know, and he's going to regulate that. So, and potassium and calcium into the cell. So his job is to regulate who comes in and out of the club. That's what he does. Hey, you can go in. Yep. Hold on. We have max capacity. When 5 people come out, I'll allow 5 more to go in. So you see, as 5 potassiums come out, he'll let 5 sodiums in, right? So he regulates what comes in, what comes out. He keeps that consistency and that functionality and that organization of how things move inside and out the cell. So look at the range though. The normal range of magnesium sulfate is 1.5 to 2.5. So once again, that's real small. That's a low number. So we already know it's a low number. Where is it? Intracellular. Low numbers are intracellular. All right. So when a patient is hypomagnesia, meaning low, that means we don't have that guy out there. If that guy's not out there, let you go into the club, guess what? You can't go in. What's he going to do to your QT time, right? That quality time in the club, the QT club. He's going to disrupt that QT time. He's going to disrupt, or I should say, the quality time inside the club. So hypomagnesium is going to prolong your QT interval just like calcium would, all right? So when a patient is hypomagnesia, as you can see in the slide, it says it's important to correct the intracellular potassium deficiency without first correcting magnesium, because a lot of times the issue might be potassium, not so much magnesium. And when you correct that, you correct magnesium. You cannot correct magnesium if potassium is a problem. You won't correct it. So you always got to correct potassium first, okay? So hypomagnesium, ECG changes, and hypokalemic, you're going to have a prolonged QT interval, right? That little guy is not in front of the club no more, so he can't let you in. So your quality time in the club is delayed, right? Quality time, QT, he's not letting you in, so you stay outside longer, you have a prolonged QT interval, which can cause ST depression, right? Damn, I'm depressed, I can't get in the club. So you'd have the ST depression. And you can have that inverted T wave that kind of coincides and could look like depression. And you can have flattening or inverted P wave as well. You can have that widening QRS, so that's a problem too, because those widening QRS could look just like a ventricular rhythm, right? Think it's VTAC or something. It could put you in torsades. Lacking of magnesium will put you in torsades. That's why when somebody is in torsades, it's most likely because they hypomagnesium. So if they're hypomagnesium, that means we got to give them mag, so we could regulate this. So we could get rid of that polymorphic VTAC, which is AKA torsades de points, right? So if you have a patient who looks like VTAC, and you confuse if it's polymorphic or not, and their resistance to the treatment of the antidysrhythmic, we could consider maybe giving magnesium sulfate, all right? But keep in mind, if they have they're on DIG, have DIG toxicity, magnesium can make matters worse, okay? So let's talk about the flip coin to this, all right? The flip coin is hypermagnesium. Now we got a lot of these guys that can let you in. So guess what's gonna happen to your quality time in the club? That QT is gonna shorten, all right? So now you get to get in a lot quicker. So it increases. So I like to go back 1 second. So torsades de points, right? What happens to the cell? What happens with the cell in torsades or polymorphic VTAC is the cell membrane becomes unstable. So there's no more regulation. There's no more who's coming in and out. People are just doing their own thing and things get crazy. And that's when we see torsades. So by giving magnesium, bringing more of those guys to the front of that club, they start regulating. Magnesium starts stabilizing the cell membrane, regulating the influx of potassium and sodium, getting that normal QRS complex. So in torsades, we kind of give mag first so we could stabilize cell membrane. And no different when we get into the podcast, and you see the podcast when we start talking about eclamptic and preeclamptic patients. They have so much toxicity. Waste product toxemia is what it happens. What's going on is the toxins start affecting the cells of the brain that they become unstable. That's why we give magnesium, because what's magnesium going to do to those cell membrane? It's going to stabilize it, and it's going to stop the abnormal electrical firing of the cells of the neural cells inside the brain. So that's how we stop the seizures, by giving them mag in preeclampsia, because it stabilizes those cells. All right? And we're going to talk, like I said, more about that. I'm just giving you a little segue, a little taste, a little sizzle reel of what that's going to be like when we talk about preeclamptic. And you can see how understanding how these electrolytes and how things work at the cellular level is so significant, so important to know, because you're going to know exactly now how things work and who you could use these medications on and will benefit from it. So hypermagnesium, increased PR and QT intervals is gonna shorten it, because there's a lot of those guys now to let you in and out, right? The P waves will decrease if it's variable. Same thing with the T waves. It can actually show a complete heart block, which is a 3rd-degree heart block. So as we move on to another electrolyte, we're going to talk about sodium. So sodium is known as Na positive, right, for natremia. That's what sodium is. Sodium is excitability, man. It creates excitability. Gets you excited, right? That's why anytime sodium moves, it creates excitement. What follows? He's a leader and everybody follows. So water follows him. Everything follows sodium, right? So it acts as the majority intervascular ion that influence that serum of osmosis. Osmolality, I always have problems saying that word. But he does that by allowing to move, and water follows. So we want to make sure, whoa, look at this number. Look at the normal levels, 125 to 145. Whoa, high number. So because it's a high number, guess where it sits? It sits outside the cell, right? It's an extracellular ion, all right? Opens up the cell membrane channels and starts the action potential. Listen, it opens up the channels. That's why we call it the sodium channels, right? And it's a sodium-potassium pump that opens up these sodium channels, right? So he's responsible for the movement of the opening of those channels, is sodium, all right? Hyponatremia, low sodium, as hypernatremia is high sodium, really have no significant impact, believe it or not, on your ECG changes. So you can't really say to yourself are these ECG changes secondary to hypo or hypernatremia? And the answer is no. But it's significant when it comes to the movement of water, when it comes to intracellular hydration versus extracellular hydration, right? Hypotonic, hypertonic, tonic, isotonic. Sodium plays a huge role in that, okay? So that kind of sums up my quick podcast that I wanted to do for you guys on electrolytes. I hope it was beneficial. I hope you understand the club concept. That's how I remember. I kind of always associate something with something that I like to do. I don't do clubs no more. I'm too old for that. If I go to a club, it takes me 4 days to recover, so it's not worth it. But for you young people, I know you have no problem. But anyway, I hope you enjoyed this podcast of electrolytes. If you have any questions, you know how to reach out to me. You can drop me an email at fmarquez@omi.edu here at Orlando Medical Institute. All right, look forward to see you guys and talk with you guys in class. And I hope you enjoy the next podcast series.